The following podcast is part of a certified educational activity titled Bringing Precision Oncology to Early Stage Lung Cancer with Adjuvant EGFR-Targeted Therapy leading the way. What thoracic surgeons need to know and do. Access the entire activity and complete the post-test at peerview.com/FYQ860. Downloadable slides and practice aids are also available.
Hello, we would like to welcome you to our peer review program today. We will be talking today about surgically resectable lung cancer with EGFR mutation and novel discoveries, trials, and therapies in lung cancer and EGFR setting. My name is Boris Sepeshian. I'm a thoracic surgeon at MD Anderson Cancer Center, and I would like to also introduce my colleague, Tina Cascone, who is a medical oncologist at the Department of Thoracic and Head and Neck Medical Oncology with outstanding expertise in neoadjuvant therapies in surgically resectable setting, as well as adjuvant therapies.
Thank you, Boris.
So today we will talk about understanding the gaps and opportunities for improvement in surgically resectable lung cancer, mainly with EGFR mutations. We will also present to you the data which we base this on, as well as where the future of surgically resectable lung cancer in the EGFR setting is going, and we will present you some cases and answer some audience questions. We'll start with the understanding the gaps and opportunities for the improvement in lung cancer. As we all know, for decades, surgical therapy has been the mainstay of treatment of lung cancer and really offered the main opportunity for either cure, local regional disease control, or prolonged survival. However, through science, we have learned that many of the lung cancers actually are driven by mutations, and over the years, drugs have been developed in this setting to target these mutations, and many of these drugs are actually currently available in stage 4 setting. And slowly, over time, they are now being tested also in surgically resectable setting. And as you can see, we can potentially divide lung cancer into about thirds. About a third of the lung cancers actually are KRAS mutations, and about a third of them have some sort of a targetable mutation, either EGFR, ALK, ROS1, RET, NTRK, BRAF, MET14, and as I mentioned, KRAS. And we have also learned a lot about tumor microenvironment, and that's where immunotherapy comes in. However, today we're going to mainly talk about EGFR mutations, but as you can see over here, especially in the metastatic setting, all these other either mutations, alterations, or rearrangements that could be tested, they already have targetable drugs and they are being used in the metastatic setting. However, despite of this knowledge, we as a group don't do as good of a job testing all the patients for these mutations. I would say that all the patients in the metastatic setting have essentially 100% indication to have their tumors tested, especially the non-squamous, so adenocarcinomas should always be tested to see if there is any sort of a targetable mutations where we have developed specific drugs for their treatment. But even in this setting, you can see that approximately 25% of patients still do not necessarily get this testing. And I think we need to be aware that even in the surgical setting and for tumors greater than 3 centimeters in size, there certainly is a standard of care to test the tumors at least for the EGFR mutation. As I mentioned, surgical therapy for decades was the mainstay of treatment of stage 1 through 3 lung cancer, and it took, honestly, multiple decades to demonstrate the benefit of adjuvant chemotherapy in the setting of surgically resectable lung cancer. And many of these trials are well known, including the LACE meta-analysis, which demonstrated overall benefit of chemotherapy in the adjuvant setting for about 5%. However, as you can see, with all of these trials, the benefit really increases with stage. So we now use chemotherapy for tumors greater than 4 centimeters in size, but the benefit certainly increases in stage 2 and stage 3. I think that we should note that these trials took number of years to complete because of primary outcome being overall survival, and many of them still used AJCC6 staging system. Some of them use AJCC7 staging system. And so as we look at now the 8th staging system, We need to look at some of the nuances and indications for chemotherapy, but there's no question that adjuvant or actually even neoadjuvant chemotherapy have benefit in surgically resectable lung cancer, at least in tumors greater than 4 centimeters in size. So we're going to, at this point, talk a little bit more about the EGFR mutation. And for the surgeons, I think the most important thing is that our current data suggest that we should be sending off the tissue specimen or potentially liquid biopsies as well on patients with non-squamous cell carcinomas. So adenocarcinomas that are resected and greater than 3 centimeters in size. It is recommended that all of these tumors get profiled based on some of the data that we will show you from the ADURA trial. This is the complexity of EGFR alterations in lung cancer, and when we send off the specimen for mutation analysis, we can get actually variable results, and they could include either exon 18, 19, 20, or 21. These alterations are really quite complex, but I want to highlight that the most important ones to remember are exon 19 and exon 21, which are currently targetable with drugs and are part of standard of care for surgically resectable lung cancer from stage 1B, which are now tumors greater than 3 centimeters in size based on the AJCC 8 staging. So again, I just want to highlight that it's exon 19 and 21 that are targeted with the drug osimertinib, and those patients qualify for standard of care adjuvant therapy that we will go through. As mentioned before, the EGFR was actually discovered as a driver mutations quite a bit ago, and it has really made its way into the treatment of patients in the metastatic setting. Just like the previous trials with chemotherapy, it does take a really long time to run adjuvant trials, especially with the outcome of overall survival. And that's why it may have taken years for us to really discover the benefit, as we will show you in the surgically resectable setting. Over the last 10 or 15 years, the evolution of understanding of EGFR drugs have actually gone through numerous stages, and we are now at the third generation of drugs, which is the osimertinib, and a lot of research goes into understanding these tyrosine kinase inhibitors, as well as what drives resistance to treatment. However, at this point, we are already at the stage of third generation of EGFR inhibitors. Now, what is the potential of this adjuvant therapy after surgery? As we all know, the old surgical dictum has always been that if we can resect the disease, we can offer the patient the most cure. But we do need to understand that even a 1 centimeter tumor actually represents 1 billion cancer cells and a tremendous potential for either mutations or ability of these cancer cells to metastasize. And therefore, even in early setting, there is certainly a risk that a micrometastatic disease may develop. So it is important to combine treatment not only by resecting the visible disease that we do as surgeons, but also try to understand the concept of micrometastatic disease and potential recurrence and how we can decrease the level of recurrence. So the goals are to really, obviously, to achieve cure, which we achieve as surgeons through local regional disease control, but we have to understand this biology, control as well distant recurrence or local regional recurrence. And we also need to keep looking to identify patients who may not benefit for any of the adjuvant therapies and may potentially still be cured with surgery alone. And there's a lot of research going into this area as well. So at this point, I'd like to introduce my colleague, Tina Cascone, who will take us through some of the trials that led to the approval of standard of care therapy with EGFR inhibitors.
Thank you, Boris. Thank you for having me. Such a pleasure to be here, and thank you for this wonderful summary to this point. And you're absolutely right. Definitely, the pipeline of EGFR targeted therapies that we have at this point in time has seen an incredible evolution over the past 15 years. And as you mentioned with osimertinib, we are at the third generation. We're definitely evolving towards more advanced inhibitors that can help us to try to circumvent mechanisms of resistance to the prior generation. But let me summarize for you here the clinical trial data that tested and evaluated earlier generation tyrosine kinase inhibitors in patients with stage 1B to 3A, in this case, EGFR wild type and EGFR mutant non-small cell lung cancer. These are the results of the RADIANT trial published a few years ago by Dr. Karen Kelly and colleagues, where you can see on the left the DFS didn't really change, didn't have any changes in the intention to treat population between placebo and erlotinib with an hazard ratio of 0.9. But in the EGFR mutant subgroup, there was an encouraging improvement in the DFS when patients were treated with adjuvant erlotinib as compared to placebo with an hazard ratio of 0.61, although this didn't achieve statistical significance, mainly because of the hierarchical design of the study. The SELECT was a phase 2 trial published now a couple of years ago of adjuvant erlotinib in patients with resected EGFR mutant non-small cell lung cancer. This trial demonstrated an improvement in the 2-year DFS in EGFR mutant population as compared to the molecularly matched wild type population with an unchanged safety profile to what we know with erlotinib and second generation TKIs. And then I want to point out here the adjuvant CTONG phase 3 trial, which tested postoperative adjuvant gefitinib versus platinum-based chemotherapy in patients with stage 2, 3A EGFR mutant non-small cell lung cancer. You can see here there was a benefit in DFS with gefitinib as compared to cisplatin and vinorelbine in this population of patients. Although I want to also point out that most recently the authors have reported the overall survival outcomes of this trial, which didn't seem to pan out as compared to the benefit that we've seen here with the DFS. And then, practice-changing phase 3 data from the ADAURA trial that tested third-generation EGFR tyrosine kinase inhibitor osimertinib 80 milligram once daily in the adjuvant setting for 3 years as compared to placebo in patients, as you can see on the left, with stage 1B to 3A non-small cell lung cancer, completely resected, treated with or without adjuvant platinum-based chemotherapies. Patients were stratified by stage, by EGFR type of mutation, exon 19 deletion as compared to the L858R exon 21 substitution, as well as race. The treatment was planned for 3 years and continued until disease recurrence, treatment completion or discontinuation criterion met. A primary endpoint of the study was disease-free survival in stage 2 and 3A patients, designed for superiority under the Assam DFS of hazard ratio 0.7. And this is very important to point out because of the results of the trial we're going to present in just a few seconds. There were several secondary endpoints, DFS in the overall population, overall survival, safety, and also health-related quality of life. So here we have the Kaplan-Meier curves demonstrating DFS according to investigator assessment on the left. You can see that in patients with stage 2 to 3A disease, at 24 months, 90% of the population in the osimertinib group and 44% of those in the placebo group were alive and disease-free, with an hazard ratio of 0.17 in terms of disease recurrence of death with osimertinib as compared to placebo. And you can see in the stage 1B to 3A disease at 24 months, 89% of the population of patients in the OC group and 52% of those in the placebo group were alive and disease-free with an hazard ratio favoring osimertinib of 0.2. Here you see a forest plot with the DFS benefit across subgroup in the overall population. Overall, all subgroups benefit from osimertinib as compared to placebo. I want to point out that the stage 3A population had the largest benefit, although we saw a very encouraging hazard ratio 0.39 in patients with the stage 1B. As expected, perhaps the EGFR 19 deletion had a major benefit, greater benefit, even compared to the 858R. And also patients who receive adjuvant chemotherapy had a slightly, more improved hazard ratio as compared to those who didn't. Here, I want to show you the DFS Kaplan-Meier curves by disease stage. So as we just mentioned, in the stage 1B patient population, patients who received osimertinib had an hazard ratio with 0.39 as compared to placebo. And you can see the incredible separation of the curves with incredible benefit in stage 2 and 3A patients with an hazard ratio of 0.17 and 0.12 respectively.
Tina, let me just stop there for 1 second. If you can go the one slide back. There's something that I would like to highlight over here, that the ADAURA actually included the AJCC8 staging, which has actually really changed stage 1B. Well, actually, the stage 1B tumors were not necessarily classified by size of 4 centimeters, and they have included patients here for treatment who had tumors greater than 3 centimeters in size. And so I think this is an important point, because for the longest time we had, as surgeons, kind of in our head that we should refer patients to our medical oncologists if they have tumors greater than 4 centimeters in size for adjuvant treatment. But actually now, because ADAURA included patients they didn't differentiate the stage 1B by size, and I'm sorry, it was AJCC 7, but they included tumors greater than 3 centimeters in size. So I think as surgeons, we need to think about referring patients after upfront resections for sure if they have tumors greater than 3 centimeters in size.
Absolutely, Boris. I think this is a wonderful point, and thank you for emphasizing that. And perhaps I can, going back to the concept that you just present to us, perhaps for the surgeon community, perhaps you can engage the medical oncologist early on, even when you have a really early stage in small tumors, because that can actually be very important also for profiling purposes. We can profile the tumors from baseline biopsies early on, and not only in the surgical specimen. So absolutely an important point to try to engage in a multidisciplinary setting your colleagues' medical oncology, even when you have patients with a very early stage disease. So here we have the DFS Kaplan-Meier curves in the ADAURA trial with and without adjuvant chemotherapy. As I mentioned earlier, from the forest plot, you can see that patients who received platinum-based chemotherapy in the adjuvant setting prior to osimertinib had definitely an advantage with a greater benefit in the DFS, 0.16 hazard ratio, and the DFS, the hazard ratio for the DFS in patients who did not receive adjuvant chemotherapy, as you can see on the right, was 0.23. So definitely an incredible benefit in both population of patients. But here I wanted to illustrate, we have known that EGFR mutant population seems to have greater responses to adjuvant chemotherapy, platinum-based chemotherapy, as compared to the wild type. And I think those DFS curves illustrate that very well in the adjuvant setting. The ADAURA trial didn't reveal any new safety signals. We have adverse events very well known in terms of profile with the osimertinib. And so, in conclusion, for this community, the adjuvant osimertinib is the first tyrosine kinase inhibitor in a global phase 3 trial that has shown an important, dramatic, significant, and clinically meaningful improvement in DFS in patients with resected stage 1B to 3A EGFR mutant non-small cell lung cancer. We're still waiting for the overall survival, but the benefit was unprecedented, and consistent improvement in DFS was seen regardless whether the patients received or not prior adjuvant chemotherapy, with even an improved hazard ratio with adjuvant chemotherapy, as I just shown you. And as mentioned, the safety profile was consistent with what we had known with EGFR tyrosine tyrosine kinase inhibitors in this setting. And so the FDA approved osimertinib for adjuvant therapy after surgical resections of the tumors in patients with non-small cell lung cancer with EGFR exon 19 deletion or exon 21 L858R substitution mutations as approved by an FDA-approved test. So I want to leave here some important points for discussion from the ADAURA trial, and Boris and I will do this interactively. So 11% of patients who receive adjuvant osimertinib had DFS events, as defined here, of course, by disease recurrence or death, as compared to 46%, as you can see here from these stack bars, in patients treated with placebo arm. If you look at the patients treated with osimertinib, that 11%, the majority of patients with recurrence had a local regional recurrence only, with only 38% of patients having metastatic recurrence as compared to 61% of patients who had instead in the placebo arm. And so this is illustrating how perhaps what Boris was mentioning right at the beginning of our journey here of this talk, that administering a systemic therapy, in this case osimertinib in the adjuvant setting, could perhaps really be very helpful to eliminate and suppress micrometastatic disease that can be responsible for distant metastasis.
Yeah, I think actually, Tina, if you can go just one back, I would like to make a point here as a surgeon. Looking back at this trial, I think that is remarkable that these were upfront resected patients. And even though in the institutions where we practice with Tina, we do have a tendency to give a lot of neoadjuvant treatment, but looking at the higher sort of local regional recurrence rate rather than the distant rate, that's pretty much consistent with the data in surgical literature after surgical resection of stage 1 through 3 lung cancer to have approximately 10 to 15% local regional recurrence rate. It does still speak to the importance of excellent surgery performed with nodal disease dissection, trying to obtain negative margins, etc. And a lot of judgment goes into that. But from the biology standpoint, we are definitely learning over here that these drugs, these systemic drugs, really do a wonderful job of controlling the distant disease, and we did not have this for decades. So I think that this is the main point, to study where these recurrences occur, and then also how we can improve as surgeons, not only with our surgical techniques and adequate resection, but how important it is to put the disease of the patient in the context and make sure the patient gets all the treatment, both systemic and local, as they need.
Absolutely, Boris. If we think about the fact that, as you mentioned at the beginning, the vast majority of these patients, if treated, more than 50% of them overall, if treated with surgery alone, will experience relapse of the disease. And so this is the most important setting where by administering a systemic therapy in the perioperative setting, whether in this case adjuvant, as you mentioned, in some cases and now in the context of trial, as you will discuss just in a few minutes in the neoadjuvant setting, we have the greatest opportunity to eliminate and suppress micrometastatic disease that will be responsible for relapse. Here is the breakdown of the data we are just discussing. So 11% of the patient in the osimertinib group had disease recurrence at any location. But if we look at what these locations are, 6% in the lung, 3% in the lymph nodes, and only 1% is compared to 10% in the CNS. And this is extremely important. Osimertinib has a wonderful penetration in the CNS, and this data demonstrates how we can prevent CNS disease. As you can see here, the median CNS DFS was 48.2% in the placebo arm as compared to non-reach with the osimertinib. And this is absolutely important in preventing metastatic brain disease, CNS disease in this setting. Let's talk about the postoperative chemotherapy use. We touched base on this quickly earlier. I just want to emphasize that overall 60% of patients in this trial received adjuvant platinum-based chemotherapy for a median duration of our standard 4 cycles, consistently across treatment arms. As expected, the vast majority of the patients received platinum-based chemotherapy in the stage 2 and 3A disease, and Boris mentioned mentioned about the inclusion of 1B disease here. And of course, the patients with 4 centimeters or greater in the stage 1B also received chemotherapy here. This was most frequently given to patients less than 70 years of age and in patients with a good performance status. Again, DFS in patients with and without adjuvant chemotherapy is shown here by its Kaplan-Meier curves. Benefit was seen with osimertinib as compared to placebo, regardless of the administration of adjuvant platinum-based chemotherapy. But I want to point out again the hazard ratio 0.16 and 0.23 with adjuvant as compared to no adjuvant chemotherapy, respectively. And so another point of discussion that is very important for our patient is how the osimertinib improve our quality of life of our patients. So these are patient-reported outcomes. There was overall no differences between osimertinib and placebo in the time to deterioration of what we call the SF36 health domains. The SF36 is a generic health survey. As you can see here from the forest plot, really the social functioning seemed to be improved, favored with osimertinib as compared to placebo, as well as perhaps the belly pain. I will then now pass it to Boris. He will talk to us about other trials assessing these therapies in the perioperative setting.
Well, thank you, Tina, very much. So, as we have discussed before, and even as the whole story of lung cancer, we mentioned before that it was adjuvant chemotherapy that really became the standard of care, and the neoadjuvant chemotherapy trials essentially were stopped historically when the meta-analysis of the benefit of the adjuvant treatment came about. However, most of the data that we look at from chemotherapy suggests that the benefit of treatment either before or after surgery is about the same. And so I think that we need to view this also from the biology of the cancer standpoint. I think when we look at these patients, we also need to look at, what is the situation, when is the therapy best administered so the patient can tolerate it the best. So there certainly is a concept of treating these patients early, even with neoadjuvant treatment. And I will show you some cases where the neoadjuvant treatment actually may potentially make surgical resection because of the tumor response perhaps easier, or perhaps may convert pneumonectomy into a lesser resection such as bilobectomy or lobectomy, although that may sometimes be difficult to prove. However, as I mentioned, biologically, even 1 centimeter tumor has 1 billion cancer cell, and so the cat is sort of out of the bag. So when we think about here, even without trials, we always think about giving patients all the treatment. And so that's my introduction to the NeoAdatrial trial, which actually wants to test the TKI inhibitors prior to surgical resection. And this is the study design is, again, the patient should be surgically resectable with stage 2 to 3B disease. Again, we're talking about patients who have EGFR mutations, either exon 19 or exon 21. These mutations would be diagnosed either on a biopsy or liquid biopsy. This trial has actually 3 arms, essentially testing patients, again, with standard of care chemotherapy plus placebo, then osimertinib plus chemotherapy, and osimertinib alone, and essentially asking three different questions here. Patients would receive this for approximately 9 weeks. Each cycle of chemotherapy is usually given once every 21 days. This would be followed by surgery. And primary outcome is this short-term endpoint or a surrogate endpoint that has been used in many of immunotherapy trials called either major pathological or pathological complete response. I want to define those. That pathological complete response is actually 0% viable tumor cells in the final specimen, and major pathological response represents less than 10% of viable cells in the specimen. There has been numerous studies that demonstrated association between this great response to neoadjuvant immunotherapy based on these 2 outcome measures and long-term outcomes such as overall survival. Yet these points are still not FDA approved as surrogate endpoints. However, this is continued to be studied. And so these patients then would receive standard of care, depending on which arm they were on, or up to additional treatment. And obviously all of these trials also need to measure the event-free and overall survival. And as you can see over here, patient will be followed for 5 years, and they will be evaluated in standard intervals. Now, we already have some preliminary evidence about what it's like to operate after neoadjuvant TKI inhibitors, and this was published by the group from New York about performing resections after the neoadjuvant tyrosine kinase inhibitors. There's been a lot of discussion among surgeons with the advent of these different kinds of novel therapies, such as immunotherapy and TKI inhibitors, whether does it make surgery easier? Does it make it harder? What should we learn about this? And this publication has demonstrated, it was a basically case report of 2 cases where they highlighted actually variable responses, with one patient having sort of a different quality of the tissue at the time of resection, and one patient actually had relatively straightforward resection. But if you can see over here, on the slides where the images above are pre-treatment and images below are post-treatment, you can actually see quite a significant radiographic response. So this really speaks to the effectiveness of these drugs. I have to say that my own experience in operating on patients with TKI inhibitors also corroborates what was written here and demonstrated in this article. I feel that the TKI inhibitors, the longer they are used, they do change the quality of the tissue, especially in the lymph nodes, and they can obliterate the surgical planes. And so I think surgeons do need to be aware of this. Now, the 3 months treatment that is used in neoadjuvant setting is probably not as significant, but from personal experience, I have operated on some patients with metastatic disease who have been on TKIs for 9 months or a year, and my personal experience is that those dissections are really much more challenging, and I generally approach them with an open thoracotomy approach. And so I wanted to actually mention here one of the recent cases that I had of a patient. This was a 57-year-old female, never smoker, very healthy, exercises and runs every day. And as you all know, there's more and more of these patients who we see, especially younger women who never smoked, who seem to develop lung cancer. And generally, some of these lung cancers do demonstrate EGFR mutation. And this patient had a very large tumor and was diagnosed with EGFR positive, exon 21 mutation. And she had this was her image prior to the start of the treatment. You can see up above that she actually had a large, greater than 7 centimeter tumor in the right upper lobe that was extending across the fissure into her middle lobe. There was also on a PET-CT scan evidence of a level 11 lymph node that was positive. So we staged her as T4N1, and her other mediastinal lymph nodes were negative on staging. She had small nodule in the left lower lobe, and so there was an opportunity for us to classify her as oligometastatic disease. And so actually she received 3 months of neoadjuvant osimertinib, and then we controlled this disease with surgical resection. She still required a bilobectomy. And again, I felt the lymph nodes were just a little bit sticky, but she underwent complete R0 resection, and now she will receive adjuvant chemotherapy, and she will continue on osimertinib for 3 years thereafter. Here's another trial that's in the works, and this is called ADAURA-2. And as we mentioned with the main ADAURA trial, that the benefit was in patients who had tumors greater than 3 centimeters in size. But this ADAURA-2 is an extremely important trial for surgeons, because now we're talking about giving potentially 3 years of therapy to patients with tumors from 1 to 3 centimeters in size. These are the earliest tumors that we always believed as surgeons that we can cure these patients. And as we all know, even in the earliest setting, in patients who especially have slightly higher risk features, such as tumors greater than 2 centimeters in size, or if they have lymphovascular invasion, or if more than 20% have either micropapillary, solid or complex adenocarcinoma histology, these are the patients who, even in the earlier setting, may potentially develop future recurrence. And this is the trial, phase 3 ADAURA trial. They will essentially enroll this population, patients with tumors greater than from stage 1A2 or stage 1A3. So anybody who has tumors greater than 1 centimeters in size, these patients will hopefully undergo complete R0 resection. Again, we're talking about exon 19 and 21 mutations. I want to still reiterate that. And tumor will obviously be tested for, the tumor size, LVI, tumor histology, and patients will then be randomized for adjuvant osimertinib, again for 3 years versus placebo. And again, with the primary endpoint being disease-free survival rather than overall survival, as it is a shorter endpoint than a 5-year overall survival, because as we have learned, these trials do take a long time to complete. And these are, again, the key inclusion criteria. It's essentially stage 1A2 and 1A3 patients with non-small cell lung cancer, non-squamous histology, so mainly adenocarcinomas. And again, it's exon 19 and exon 21 mutations. So obviously the patients who have incomplete resections, had either wedge or pneumonectomy, so this would be the segmentectomy or lobectomy that would be included, or any other histologies would be excluded. And I also want to mention that the field is going in this direction of targeted therapy and potentially targeted therapy in the neoadjuvant setting. There's an effort through Lung Cancer Mutation Consortium and the LEADER trial to profile 1,000 patients, anticipating that approximately 35% of patients with surgically resectable lung cancer will have one of these targetable mutations. And now we have also added the KRAS G12C mutation to this as well. As mentioned at the beginning of the presentation, these drugs are already in the metastatic setting, and the aim of the LCMC4 consortium is to enroll patients on these targeted therapy trials in the perioperative setting.
Boris, before
Yes.
we get into the discussion, I just wanted to make a comment, if I may. I actually want to commend you for offering us the example of implementing, right, 3 months of neoadjuvant osimertinib in a patients with T4N1 potentially oligometastatic disease, offering to this patient the opportunity to enjoy, as you mentioned, a pathological response, perhaps in the resected tumor, adjuvant chemotherapy in the postoperative setting, and the continuation of osimertinib for 3 years. So I think this is a wonderful example of implementing, the most effective systemic therapies really early on in the biological history of the disease, from the neoadjuvant to the postoperative setting. So it will be very important from the ADAURA trial to, tell us whether the surrogate endpoint of pathological complete response, major pathological response in this setting after TKI, as much as we have learned from the immunotherapy and chemoimmunotherapy setting, whether those surrogates will really pan out as clinical endpoints of survival benefit, of DFS, EFS, and OS benefit. So I think you gave us a wonderful example of how we can benefit our patients by implementing those strategies early on, perhaps even earlier than the adjuvant setting, and continuing the adjuvant setting to eliminate metastatic disease and potentially cure them.
Well, thank you. And I, as I think of these patients, especially this one, I think about what is the most important to treat right now, and I think that there is a little bit of a change in thinking, or my thinking as a surgeon, that when I see a patient who demonstrates this large of a cancer, it used to be, hey, let's rush the patient to the operating room and resect everything, and that was possible in this situation. But then the patient needs to go through some recovery, obviously. The tumor was very large. Perhaps some of my colleagues would approach it through minimally invasive techniques, but I think that obviously doing this through a thoracotomy, there's no harm in that. But patients really still need to recover from that. And even under the best setting, generally patients can start their adjuvant treatment usually around 4 weeks, which still delays, their systemic treatment. And this is why in this particular patient, I felt, hey, you can start your systemic treatment, and maybe we can start addressing your risk of micrometastatic disease right away, we know we are going to still have local disease control, some local disease control for this tumor. So whether I resect it tomorrow or whether I resect it 3 months later, that actually doesn't matter as much. I know I can provide that local regional disease control, but we need to address the micrometastatic disease as soon as possible. So I felt like this patient has been at least right now protected from distant disease to some extent because she received that neoadjuvant treatment. Now we resected her. She has local regional disease control. And I actually have no problem starting TKI inhibitors right away. Essentially, when she's discharged from the hospital, we don't have any evidence that there would be any detrimental effect to healing or anything like that. And when she heals for about 4 weeks or 6 weeks after surgery, she can receive chemo, as was demonstrated to be beneficial in this setting, and then she will continue on this. So I think that as we think as surgeons, it's important for us to have a good collaboration with medical oncologists and really try to create a long-term strategy for the best chance of patient being cured. Whether we operate next week or whether we operate 8 or 12 weeks down the road does not. I don't think that matters as much. I think what matters is being able to do a good job along the way, preserve patients' quality of life, and give the patients sort of the best chance there. So, and we can discuss some more of these cases, at this point. So here we have another case of a patient who is 58 years old, male, who was clinically diagnosed with T3N1 mass in the right upper lobe. So this would be a stage 3 lung cancer. And this was an adenocarcinoma. It seems like that the EBUS demonstrated that mediastinal lymph nodes were negative for malignancy, so there was no N2 disease, but again, still a stage 3A based on the new staging system. So this patient underwent actually standard of care neoadjuvant chemotherapy. As we know, it's still a little bit difficult to get all the profiling from original biopsies. Patient had a good response, underwent uncomplicated VATS right upper lobectomy with nodal dissection, and had a really good downstaging. The tumor was small, and final pathology was YPT2 and 0, but then the molecular profiling was shown, and patient was actually demonstrated to have an EGFR exon 21 mutant lung cancer. So if I resected this patient and send this patient to you, Tina, how would you approach this? When do you think the surgeon should have discussed the possibility of adjuvant therapy? And I do that sort of right away in some of these patients, especially now. Even if they get neoadjuvant treatment, I usually try to tell the patients we need to see what the final pathological specimen shows, and there may be a possibility that we have something else for you that can prevent you from other disease, right?
Absolutely, Boris. I think this is a very important point of discussion and an educational point. We should discuss in a multidisciplinary setting and with our patients early on what are the treatment strategies in a combinatorial type of approach that we can offer these patients for a chance of cure. So absolutely, the surgeons should discuss, first of all, with the multidisciplinary team, the medical oncologist, the interventional pulmonologist, the radiologist, the radiation oncologist in some specific situations. And together in this multidisciplinary setting, we can offer to our patients all the different perspectives to implement, in addition to surgery, systemic therapy based on the molecular profiling after surgery, in this case in the adjuvant setting, or perhaps in the context of the NeoAdatrial, right? Perhaps even in the neoadjuvant setting, together with chemotherapy. And let me point out an important piece of data that you briefly mentioned in the introduction, in the background, when we discuss about what does adjuvant chemotherapy gives us in terms of improvement in survival from the LACE meta-analysis. Although neoadjuvant and adjuvant chemotherapy have not been compared head-to-head, from meta-analysis, we know that 5% holds true, regardless of giving chemotherapy in the neoadjuvant or adjuvant setting. So absolutely, if the patient has received neoadjuvant chemotherapy 4 cycles, I would not give additional chemotherapy. But definitely, I would administer, adjuvant osimertinib based on the EGFR mutation that you have pointed out.
Yeah, so I want to make this point that this is what I have learned from my medical oncology colleagues, is that essentially the 4 cycles of chemotherapy in the perioperative setting seems to be the standard of care. I know that from medical oncology standpoint, in metastatic setting, the chemotherapy is giving for a longer period of time or for more cycles. But I think for us surgeons, I think remembering the 4 cycles as we talk with the patients, and 1 cycle I remember is 21 days. And so whether majority of the clinical trials, whether they are in perioperative setting, whether they are with chemoimmunotherapy, they actually use 4 cycles. So I think this is important to remember, that if we resect patients up front and then we say, if the patient asks us, am I going to get chemotherapy and how long? I generally tell patients, well, it depends how you tolerate it, but the standard, if you can tolerate it, is to get 4 cycles, and 1 cycle is 21 days. So it's 3 weeks. So it's 3 weeks times 4. And this patient already received that. So whether it's upfront or after, it's a standard. So I guess we can all agree that since this patient has an EGFR targetable mutation, you would give osimertinib for 3 years, right?
Absolutely.
And you would only stop if there were some, unexpected side effects or something like that.
I would tend to manage the side effects of osimertinib as much as possible, to still try to give the patient the opportunity to complete the 3 years course. As discussed, as we have learned so far, the safety profiling of osimertinib as a 3rd generation is pretty well tolerated. So we're definitely trying to manage and have consults on board to help us to manage this toxicity if we have issues, to try to maintain the drug on board.
Okay. We can look another case over here. So this is a 79-year-old female with a 15 pack year history of smoking, who presents with clinical T2A N0 mass in the left lower lobe. She seems to have marginal pulmonary function test and performance status of 1. She has a relatively small tumor. It is an adenocarcinoma. She undergoes lung function test, and her predicted DLCO is 35%. And she actually was offered stereotactic radiation treatment, but she refused that. She preferred surgical resection. So she underwent superior segmentectomy. So she only lost approximately 5% of her lung function for this tumor. And despite of being a smoker, she was found to have exon 19 deletion. And I would also like to make a point over here, is that even the NCCN guidelines suggest testing all patients regardless of whether they are smokers and non-smokers if they have non-squamous histology. And so even though we tend to think that EGFR mutations are more likely in patients who are non-smokers, but as you can see, they can also occur in this setting. So,
Boris, I want to emphasize that as a medical oncologist, I would encourage the community, when possible, to test all our patients.
Yes, it is standard of care to test the patient. So here are some of the questions for the discussion. So the ADAURA trial only included lobectomy or greater patients. Is this patient eligible for adjuvant osimertinib? Well, from my standpoint as a surgeon, this patient underwent the most optimal oncological resection that she could tolerate. So whether it's a lobectomy or a segmentectomy, she underwent the resection for local regional disease control and lymph node dissection. She got final staging. We cannot necessarily look at this only from the technical aspects of lobectomy, but also from the biology of the disease. And if her tumor is greater than 3 centimeters in size and she has an EGFR mutation, from my standpoint, I would refer her for consideration of adjuvant osimertinib. What do you think? Does lobectomy versus segmentectomy matter here?
No, absolutely. I think that this patient should be referred to us for consideration of adjuvant chemotherapy. As far as I'm concerned, with the AJCC 8, this is still with a 2B, a pathological resection, a T2B, as you mentioned, if I read correctly in the stem of the question. This is a patient that would benefit from adjuvant osimertinib.
Yeah, she was T2A. So I think this is where this question really comes to. If she had tumor let's say her tumor was 3.5 centimeters, we agree that she should get treatment, and you saying that you would give her adjuvant osimertinib for 3 years. Would you give her chemotherapy with PS of 1 and tumor 3.5 centimeters in size?
That's a very tricky question. So if there are no additional features that could make me think of a poor prognosis, as you mentioned, among the criteria, right, that we use for the stage 1A 2 and 3 for the ADAURA for the adjuvant ADAURA, then in that case perhaps no. In the stem of the question, I thought that she was a PT2B. That would make us consider, definitely a discussion with our colleagues. But if you have a tumor that doesn't have those prognostic negative features and that doesn't have a size that reaches the 4 centimeters, perhaps we could consider to avoid the adjuvant chemotherapy, but I would not spare the adjuvant osimertinib to this patient. This patient might benefit from the adjuvant osimertinib, absolutely.
Now, another question would be, so obviously these are some of the nuances of our care, and I think that even as surgeons, as we look at our final pathological report and see our patients in post-operative setting and discuss the pathological report and risk of recurrence when the patient asks us, I think that these are important things. But here's another question. As we know, we now also have an FDA-approved immunotherapy regimen in patients who demonstrate PD-L1 expression in their tumor greater than 1%. What if these patients concomitantly, after resection, demonstrated EGFR mutation and, let's say, PD-L1 expression of 20%? Should she be treated with adjuvant atezolizumab, which has demonstrated benefit in this setting as well, or should she be treated with osimertinib or both? Can you enlighten us on that from medical oncology standpoint?
Sure. These are situations that we really see in real life. Please administer adjuvant osimertinib to these patients. This patient has an oncogenically driven tumors and needs TKI in the adjuvant setting. The IMpower010 led to the approval of the adjuvant atezolizumab for a PD-L1 positive population 1% and above for 1 year in the adjuvant setting. Although some portion of the population in that trial had EGFR and ALK alterations, really the benefit in this population is driven in the adjuvant setting by a TKI, not by an immunotherapy. We know retrospectively that patients with these aberrations tend to not respond very well to immunotherapy. So the answer to the third bullet is osimertinib alone in the adjuvant.
Well, thank you. So that's what I learned as well, that essentially if there is a targetable mutation for a patient, that the effectiveness of targeted therapy sort of supersedes immunotherapy in this setting. I can maybe imagine that as this information gets a little bit more to the patients, I would just ask you, how would you approach a patient who says, I don't want to get chemotherapy, I heard chemotherapy is really bad. If patient for some reason just refused chemotherapy, would you be willing just to treat them? It's so much more convenient to have an oral regimen, right, with osimertinib and perhaps better side effect profile. Do you think that would be legitimate if we documented it, in the chart, to skip chemotherapy if patient really refuses for whatever reasons?
Yeah, that's an important question, and I think it's paramount to discuss with our patients what's the rationale, right, of these decisions in terms of therapeutic approach and strategies. So I'll tend to discuss with our patients why platinum-based chemotherapy could be important in this setting. But to your point, from the ADAURA trial, we learned that there is benefit in DFS from osimertinib regardless, right, of adjuvant chemotherapy, platinum-based chemotherapy. Just to remind you guys, to the audience, at 0.16, at 0.23 is hazard ratio with and without adjuvant chemotherapy. So an incredible, unprecedented benefit regardless of adjuvant chemotherapy. These patients with EGFR mutations tend to have even higher responses to platinum-based chemotherapy as compared to the wild type. So I would implement all these explanations and this rationale in my discussion with the patients. But to answer your question, if there is a refusal for chemotherapy, it would make completely rational sense to proceed with adjuvant osimertinib based on the ADAURA trial results.
Okay. Well, we have let's now address some of the questions that we have received from the audience. How can we prevent or mitigate resistance of EGFR TKI therapy in the adjuvant setting? Well, if I can comment to this, I think this is where, and maybe he's not answering this question directly, but I think that we mitigate the resistance also by resecting the disease early. So we are not allowing the new clones of cells to develop. But once primary tumor is resected and we potentially dealing with just some micrometastatic disease, I think at this point it's probably very difficult for us to say how else we could sort of mitigate resistance. I mean, Tina, can you tell us a little bit more about resistance, I think, that we have learned from in the metastatic setting for these TKI inhibitors.
Yes, and I think you very eloquently summarize for me how we can potentially mitigate resistance. I think it's offering our patients right early on in the biological evolution of the disease access to these therapies. As you mentioned, we can not only eliminate, suppress micrometastatic disease, but perhaps early on we can minimize the prevalence of clonal resistance and the takeover of those clones in determining relapse. In the metastatic setting, mechanisms of resistance are being learned more and more, and we're actually implementing novel strategies based on the specific type of mechanism of resistance that we see at rebiopsy when there is a new lesion after a progression on TKIs. Those mechanisms are very different, right, between one drug and the other. But definitely having the patients to access those drugs in the postoperative setting should help us to prevent clonal.
And this is exactly how we progressed, right, from first generation to third generation of TKI inhibitors, because the resistance was studied mainly in the metastatic setting. I think here's another important question. What advice would you offer to practicing in the community, and how to operationalize and improve the collaboration between oncologists and surgeons? I think this is incredibly important. I think that we all need to view ourselves as a team, trying to help patients achieve really the best long-term outcome with their lung cancer, and therefore this communication should happen, I think, early. Even surgeons just essentially informing their oncology colleagues, or that they may be resecting someone, let's say with stage 1 or stage 2, that they will try to expedite the profiling. I think that it's important to understand the local resources in terms of sending tissue, discussion with pathologists, discussion with other within their hospitals about the resources of how to get the surgical tissue, surgical specimen to an appropriate testing lab for EGFR mutation, and alerting both patients, obviously, and medical oncology colleagues about that these results will be coming, and then they are important in decision making in the adjuvant setting.
Boris, if I can add on that, I would just like to mention for a few seconds to please, to the community, consider these conversations as an important variable in determining the outcome for your patients. So these are absolutely critical to have early on. Also, because now we have trial with these agents in the stage 1A, 2, and 3 setting. So
yeah, and
all your patients, even with stage 1A, to your medical oncologist, and have these conversations early on.
Yeah. And I would like to address also this last patient over here, that in the future, do you anticipate that it could be a hurdle to adopt neoadjuvant targeted therapy regimens, given the time to surgery is very important? Well, I don't view it that way. I do think that the time for surgery was a concept that maybe we are changing our mind on this. Maybe the time to surgery is important if we don't have patients who have a targetable mutation. But if we do have patients who have a targetable mutation, they're really quite protected with these drugs. And again, we are addressing local disease, the one that we can see on the scans. And then we also need to address the possibility of distant spread and micrometastatic disease. And so if we have patients who have no mutation, then these neoadjuvant therapy drugs, I have honestly, on targeted regimens, I have yet to see patients who would progress on that regimen and would not benefit from it. So I do view it a little bit differently, that rushing to surgery is not as important, that it's important to have a comprehensive plan. Okay, I think we're coming to an end. So I would like to just summarize and thank everybody for their attention, that the standard of care in lung cancer is changing, and that surgical resection for local disease control is important, as well as profiling patients, mainly for EGFR mutation that is now standard of care. In the future, we may see other targetable therapies become standard of care. But I think it's important to collaborate between surgeons and medical oncologists, and also with our pathologists and tissue for sending it for profiling, so the patients can get all of their treatment for their benefit. Thank you very much.
Thank you.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed in collaboration with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FYQ860. This activity is supported by an independent educational grant from AstraZeneca.